Well, good morning, everybody. Thank you for coming into our grand rounds, October 21st. We have a very special guest speaker today, who I'm going to ask Dr. Dan Cole, who's made today's session possible, and we are very grateful for him to introduce our speaker. So without further ado, Dr. Cole, please go ahead.
Well, thank you, Mark, and it really is an honor and a privilege to introduce Bill, a good friend who has a lifetime work in one of the great issues of our time. As I've gotten to know Bill, we can have a 5-minute conversation, and I have always walked away with a wow. I have learned a lot from Bill. So we have 60 minutes, and I am going to give a very short introduction because I know Bill, and let me try and quote him. I think what he would like is to people to be more compelled about what he has to say rather than his accomplishments. But Bill is the Chief Diversity and Equity and Inclusion Officer for the Accreditation Council for Graduate Medical Education. He has a lifetime work in this area. He's been the Chief Academic Officer, EVP, for the Ochsner Health System, Professor and Deputy Provost at the University of Chicago, and Associate Dean at the Pritzker School of Medicine. He's a current Executive Committee member of the Joint Commission, and he served on boards for AMA, MBME, and ACGME. He has been a president and board chair of local and state medical societies in Illinois, and chair of the National Medical Association's Anesthesiology section and the American Medical Association's Council on Medical Education. He's a board certified anesthesiologist, so at heart, he's one of us. He's graduated from the Pritzker School of Medicine at the University of Chicago, also earning a PhD in biophysics and theoretical biology. He did his internship at the University of Chicago and residency at the Massachusetts General Hospital. Thank you, Bill, for spending time with us today, and I look forward to the next 60 minutes.
Thanks, Dan. I really appreciate being here, and thank you for the kind invitation. So the importance of the work that we're doing, I'm going to point out in the first part of the lecture, why diversity matters. And in the next part of the lecture, I'm going to tell you a little bit about what happens when the learning environment isn't as inclusive as it can be and the impacts it has on learners. In the last part, we'll talk about the newest common program requirement change that deals with first-time pass rate on the board certification exams. So I'm an employee of the ACGME. I receive a per diem from the AMA to serve on the board of the Joint Commission. So this year has been a very special year. COVID-19 has taught us some very important lessons. It reminded us that, in fact, health disparities with respect to race and ethnicity exist and underlie many of the deaths that we saw in COVID. In my hometown, Chicago, we saw that the first 100 people who died of COVID, 70 were African American. In the upper left-hand side, we see an article from Health Affairs, which really points out a very interesting phenomenon, that not only are there differences with respect to health disparities, which impact African Americans in the yellow color more frequently than other groups that lead to the increased risk of COVID death that we saw so far this year. But if you look on the right side, you'll see that the roles that underrepresented minority people play is a little bit different than what you see with respect to whites, in that the blue and green kind of aqua colors at the top of the right-hand side look at people who are able to work from home, whether their work is essential or non-essential. The red bands in the middle show you non-essential workers and essential workers who are unable to work from home. And you see that Latinx individuals and African-American individuals are overrepresented there. One of the things that you'll see actually more commonly seen is that African Americans represent a larger proportion of healthcare sector workers. And these are the individuals who are at greater risk for COVID infection. And so by looking at the underlying health disparities that are there and the types of roles that people play in society, we see that they come together to increase the risk of certain groups as a function of race and ethnicity of being exposed. Well, on June 5th, after the murder of George Floyd up in Minnesota, we saw that there was now national and international unrest because of the injustice of anti-Black racism in particular, but it gave the opportunity to give voice to a number of the problems with racism that we saw in society. And that it impacted both physicians and non-physicians. It dealt with areas of health disparities and really put everybody on alert that we have more problems to solve in these areas than we thought we've made progress on. And people have actually termed it a syndemic. That is, when there are two or more afflictions interacting synergistically, contributing to excess burden of disease in a population, we have racism and COVID-19 that are all involved in the medical field, such that these things may include epidemics of both social disease as well as physical biological disease that contribute to the proliferation, as we've seen in the COVID situation, as well as the racism situation. This is a former student of mine from the University of Chicago, who's now a fellow in cardiology at Wash St. Louis. And she published on the American College of Cardiology website this particular compelling essay on 8 minutes and 46 seconds, the time it took to murder George Floyd, that should change the way that you practice medicine. And what she asks is that if George had come to see you, instead of writing this as a 56-year-old male with a history of no-shows and non-compliance with his medications, consider whether your note should begin with this acknowledgement in your mind. This is a 56-year-old African-American man, recently violated, burdened by disease, managing unmanageable stressors. Yet despite all of those barriers to him being here, he presents for one fair shot at his health today. These are the things that we have to consider. And so many organizations came together to really pledge a committed effort at eliminating racism where we can, treating people with equity, and that included Tom Naska, who's the CEO of the ACGME. And he writes, it's our collective duty to advocate for all our patients and to care equally and equitably for all our patients, even as we care about our patients. We must use the support and appreciation the public has provided us due to the heroic, altruistic work we've seen in healthcare across the nation in response to the COVID-19 pandemic. And we must leverage that heightened social standing to speak out on behalf of everyone, promote equity and fairness, demand justice in all its forms, especially in the provision of healthcare to those who require it. Many organizations had similar statements during that period of time, but the ACGME had actually been working on this prior to this summer's unrest. And in fact, I was asked to chair a committee on this 2 years ago, or 3 years ago now, that focused on diversity in graduate medical education. In the end, the recommendations we put forward to the board were all accepted unanimously by the board. And one of them was to create an office, specifically within ACGME, with a national focus on intending to make graduate medical education more diverse and inclusive. And Tom Naska then in turn invited me to serve as the first chief, and so I accepted gladly to take on this work and further the mission of the ACGME. About 10 months ago now, I was able to bring on Dr. Bonnie Mason. Dr. Mason's an orthopedic surgeon who ran an organization called Nth Dimensions. Nth Dimensions was focused on trying to increase diversity, equity, inclusion in orthopedic surgery training. And she showed a wonderful slide at a talk I saw of hers once that had over 100 individual pictures of individuals who are now orthopedic surgeons because in part they were involved in Nth Dimensions prior to the time they were admitted to orthopedic surgery residencies and persisted through their training. I felt that she had her ear to the ground with respect to issues going on in graduate medical education. I often refer to her as the resident whisperer because she hears things about what are happening to residents around the country faster than almost in real time. So she's a great colleague and she's been able to further the work we've been doing over the last several months now. I've been in the position for about 1.5 years. But ACGME was working on these sorts of issues and health disparities even before then. I point you to the right side of this slide, which shows the clinical learning environment review process. And in Healthcare Quality Pathway 5, we ask residents, fellows, and faculty members to engage in education on eliminating health disparities. And the CLEAR team goes in and assesses by talking to people around the institution in a formative way, whether or not institutions are focused on this sort of work. Healthcare Quality Pathway 6 asks residents, fellow, and faculty to engage in clinical site management initiatives to eliminate healthcare disparities. And so if you'll see the data from 8 years ago, that's 2 years after the CLEAR program started, in cycle 1, you'll see that only about 4% of CEOs felt that they had a systematic approach to elimination of health disparities. When it was repeated 2 years later, in the second cycle, you see that that number didn't change one whit. Those were the 2 lowest rated scores in all of CLEAR in this formative process. And so we weren't really forming things. But in the last cycle that was measured, that was 2 years ago, we're getting data for the most recent cycle, which is just completed. We saw that now 20% of CEOs actually appear to be developing a systematic approach. And we're still around 2% or so of people who actually had a systematic approach. That means that we're trying to educate everyone who trains in residency programs across the country on how to eliminate health disparities, which is a major facet of what the ACGME wants to do. We want to improve healthcare quality because that's our mission through resident education and assessment. But new things that the ACGME board passed in 2018 that went into effect July 1st, 2019 are in the common program requirements. So along with starting our office, they built these new common program requirements, including Section 1C, which enjoins programs and partnerships with their sponsor institution to engage in practices to increase workforce diversity and to improve inclusivity. Section 6B6 was modified, which enjoins programs to provide a civil, equitable, and professional learning environment. Section 2A4 and A10 was always there and protects whistleblowers from retaliation. It's asked program directors to ensure that there's a safe environment for this. And then Section 5 changes now shift the emphasis to now looking at ultimate board rate and continuing to look at first time pass rate with the idea that we will eventually flex into more of a consideration of ultimate pass rate as opposed to first time, which we think will have an salutary effect on increasing diversity in residency programs and maybe looking at better elements of quality. So the idea that there was racial and ethnic disparity in healthcare is longstanding. In 2002, Unequal Treatment was published by the National Academy of Medicine. They found disparities across a wide range of clinical settings, and it was associated with higher mortality in minority communities. And why does this persist? Well, this is Brian Stevenson, who wrote the book Just Mercy, who's the founder of the Equal Justice Initiative out of Alabama. He spoke at the AMC Learn, Serve, Leave annual meeting in 2019. And what he said is that there's an empathy gap in society and that we become comfortable with health disparities because they're not our problem, and that we become disconnected because we're not proximate to those who are suffering. William Julius Wilson would add, the sociologist from Harvard, would add that we live in hyper-segregated communities in general in the United States. And what that really means is that we're not where people who are suffering really are, so we don't really view it as a problem that we have to solve. It doesn't have the immediacy. So Václav Havel, a Czech leader, said that we spoke of the willingness of the spirit to sometimes be in hopeless places and to be a witness, to develop this empathy that we need to have in order to address major problems in our society. So I point you to the AMA Health Workforce Mapper. It's a tool the AMA has that allows you to plot every cardiologist practice in the United States. And what I show you is Chicago, where this cluster here on the south side of Chicago is the University of Chicago group. Up here is Northwestern, and along the North Shore you see other cardiologists. But I want to point you to an area that's just west of the University of Chicago on the other side of I-94, the Dan Ryan Expressway, which is called Inglewood. Now, the interesting thing about Inglewood is if you caught the New York Times last month, you saw this interesting article that looked at life expectancy in Inglewood that showed you 60 years old. The life expectancy in Streeterville, that area here, is about 90 years old. A 30-year life expectancy difference just based on your zip code. It's an L ride away. And what it really points out is that there's a geographic factor that's involved with health disparities that really exceeds what we may believe it to be. That there's a 30-year gap based on where you live probably means that there's not co-location of physicians, because if you look back at the Health Workforce Mapper, you see that that area is completely absent of cardiologists, and here's one of the major killers of African Americans. So what my argument is that you have to have both physicians who are willing to work in underserved areas, who practice there, and who are willing to take patients in those communities to help to eliminate health disparities. And some would argue that it's an insurance question, that people who don't have access don't have insurance. And so this is a Medicare study that was done in US News and World Report, in which they were assessing the quality of hospital care. And what they found is that looking from 2012 to 2018, that Black patients received 67,000 fewer orthopedic procedures than would have been the case if they'd been equitably distributed, which means that they're not getting access to the orthopedic surgeons who can do the procedures, and that fewer procedures are being done. So with insurance being equal across the board, we still see that African Americans are being undercared for because we don't have access to those physicians who are providing that particular care. So our foundational principles of why we're doing the work we're doing is that we believe that healthcare disparities exist because we lack the societal will to view them as a form of unacceptable healthcare quality deficiencies and to apply an equity lens. In my role in Joint Commission, one of the things I'm trying to advance is the idea of thinking of healthcare disparities as a healthcare quality issue, and to start measuring those healthcare quality issues and assessing those institutions who aren't trying to improve those healthcare quality deficits. Health equity is a means to achieve elimination of healthcare disparities. So health equity is a goal. And how do you achieve health equity? Well, we think that one way of doing it, and so is the Institute of Medicine or the National Academy of Medicine now in their report on equal treatment, the goal is to increase a workforce that's more likely to help you achieve health equity. And so inclusion is the tool to ensure that that diversity is successful. And let's make an argument about why that workforce to achieve health equity might involve underrepresented minority individuals. So if you want to eliminate healthcare disparities, and that's consistent with our mission, which is to improve healthcare and population health by assessing and enhancing the quality of resident physician education through advancements in accreditation and education, that's our new mission statement for the ACGME. Our vision, which we cited as one of the bulleted points here, is that we envision a healthcare system where the quadruple aim has been realized, aspiring to advance the transformed system of GME with global reach that's immersed in evidence-based, data-driven clinical learning and care environments defined by excellence in clinical care, safety, cost-effectiveness, professionalism, and diversity and inclusion. So the idea is let's educate physicians who are more likely to serve underserved patients, locate in minority communities so that we can increase healthcare access by improving trust, communication, and outcomes for those most at risk. So who's going to practice in underserved areas when they graduate? Well, the AMC asked matriculating students on a matriculating student questionnaire back in 2019. And what they found is that 60% of African Americans confidently said that they're going to practice in an underserved area upon graduation. 50% of Native American indigenous people said that's where they're going to practice. We're down here with Latinx individuals around 40%, 45% of those individuals saying that's where they're going to practice. White and Asian physicians in the mid-20s or so. If you ask those individuals 4 years later as seniors, and this data comes from the graduation questionnaire that was administered in 2007, Black and Native American individuals are still around that 50% mark. You'll find that Latinx individuals, 32% say that they're going to, 21.8% said they're considering it. And white and Asian individuals down in the teens. So the idea is if we increase the diversity of individuals in medical school from underrepresented groups, we probably have a greater chance of having those people to return to those areas. But this is data from the Cambridge Health Alliance that was published in JAMA, which really looks at what your odds ratio are of seeing a Black patient based on your race as a physician relative to a white physician. So if you're a Black physician, the odds ratio of you seeing a Black patient in general is about 23.25 times greater than seeing a white physician. If you are a Latinx physician, your odds ratio of seeing a Latinx patient is about 19 times greater than a white physician seeing a Latinx physician. And if there's limited English proficiency at your home, about 18 times greater. If you're an Asian physician, your propensity to see Asian patients is about 26 times greater than it is for a white physician to see an Asian patient. This racial concordance that we see between patients and physicians has a number of sort of factors that come into play as to why it occurs. But in certain areas like primary care, Peter Bach and his group actually looked at this and published in the New England Journal of Medicine a few years ago, showing that a Black physician in primary care was about 40 times more likely to see a Black patient than was a white physician. And so it's not forcing people to work where they don't want to work. It's not limiting patient access to the best physicians available. It's not forcing people to see only doctors of their own race, but proximity is an important factor, but not the only one. You have to have physicians who are willing to work in disadvantaged communities and accept Medicare and Medicaid reimbursement. And patient choice also plays a role. So Somnath Saha out of Oregon looked at Commonwealth Fund data, and he found that minority patients who choose a racially and ethnically congruent relationship with a physician wasn't solely based on geographic convenience, and that there was some selectivity that was involved in choosing that physician that was based on race. In fact, what he showed is that if you're African American, it's twofold that you chose your African American physician because of race, and if you are Latinx, it was fourfold. And if it was race, if it was language, rather, it was twofold that you chose that physician. So what might be driving this preference? Well, the idea that trust, respect, communication, and self-advocacy are increased in racially congruent relationships has been certainly shown by work with Lisa Cooper, Neil Poe, Janice Blanchard, and other scholars. The intention to adhere to medical advice is enhanced in racially concordant relationships, and that patient satisfaction was also increased. And until recently, the question of improved clinical outcomes was also a question, but I think we've now resolved that to some extent with more recent work. So this is Lisa Cooper and Neil Poe in 2004, looked at the history of evidence that African-American physicians and Latinx physicians disproportionately care for people in those same communities. They cite a 1975 study out of UCLA. I think it involves David Carlisle, as a matter of fact, as one of the authors, that talked about the propensity that minority physicians have to choose primary care specialties and to serve patients of their own ethnic groups. They follow these papers through a number of generations, and they conclude at the end of this that there's ongoing racial and ethnic health disparities, that the role of ethnic minority physicians in caring for underserved populations is strong, and that argues that we should try to increase diversity in medicine, and the link between concordance between physician relationships has an impact on healthcare processes and outcomes. Well, this is the paper that I found really fascinating, and it's a study that I probably would have never thought about doing, but it really is very interesting. So Marcella Alsan, who was at Stanford at the time, now moved over to Harvard as a healthcare economist, an MD, PhD, and Owen Garrick is out of Oakland, a physician there who runs clinical trials organization. And what they showed is that if you take African-American men in Oakland and you randomize them to a practice with both Black physicians and white physicians, you'll find that Black subjects were more likely to talk about a problem, their medical problems, with a Black doctor and talk more extensively and at longer lengths. They also found that Black doctors were more likely to write additional notes about their subjects than were white doctors seeing those same Black subjects. And they found that the impact, through some very elegant mathematics they did in the paper, that the impact on cardiovascular disease was significant, leading to a 19% reduction in the Black-white male gap in cardiovascular morbidity and about a 10% gap in mortality. That's amazing that you can reduce those deaths that are the principal cause of death of African Americans by that much, simply by having concordance between physicians and patients. They felt that most of this was due to the fact that diabetes, cholesterol, and invasive testing was up nearly 20% in those relationships of racial concordance. They even found that flu shots were more likely in concordant relationships. Well, just last month, in the proceedings of the National Academy of Science, a very interesting paper came out that looked at 1.8 million hospital births in Florida between 92 and 2015. They showed that the Black newborn death rate was threefold that of white newborns. But they found that when there was patient, that is newborn race, concordance with the physicians who cared for them in the newborn period, that by having a Black physician, if you were a Black newborn, you could reduce the neonatal death anywhere between 53 and 56% compared to if you were a Black newborn cared for by a white physician. Now, there's no explanation as to why this occurred, so causality is not talked about here, but the idea is that you look at these relationships and you say there is something about a concordant relationship that may have impact on healthcare disparities, and we have to do more to figure out how to produce more of those physicians and to understand what's happening in these environments. Interestingly enough, in the same paper, they point out there was no difference in maternal mortality, a major problem among African-American women when there was racial concordance with respect to the physician. But having a more diverse faculty is also important in improving healthcare. It turns out that minority scholars tend to study problems disproportionately that impact minority communities, and often to their detriment. You'll find that study sections and funding don't really correspond with the same sort of research that minority investigators may choose to study. And so because of that, at their own detriment, they don't get funded. You also find that racial concordance may play a role in the recruitment of minority patients into clinical trials. And we've seen multiple studies who've suggested this. And then we find that minority faculty also serve as role models, mentors, and advocates for minority students in the educational process. There's plenty of data that suggests that having more diversity in medical school admissions committees improves outcomes of those committees. Same thing is true in terms of residency. Well, the role of the teacher also dispels bias and racism. That is, if you look at the types of racism, as Dr. Kamara Jones did in her analysis of when she was president of the Public Health Association, American Public Health Association, she describes racism as an institutional or structural, personally mediated or internalized. Institutional structural racism is kind of built into the fabric of society. Personally mediated racism is that racism that most of us think about when we think of racism, which is the individual acts of bias or individual acts of discrimination or thoughts of bias on the parts of individuals. And this is something that I want to really de-emphasize because I think the bigger problem is structural racism built into our system. But internalized racism is also important, and that's what I'm going to focus on in this slide. The idea that you as a minority person or a marginalized person believe what society is telling you about the stereotypes associated with your marginalized group, and you internalize that. And so Stereotype threat, for instance, which is described by Claude Steele, is a really important element of this, which is that you don't believe that you can actually do as well as somebody else because of societal pressure not to really bring out the strengths that you have. And when you're taking a standardized test, for instance, there's the idea of rumination, that you're thinking about societal pressures on you other than just thinking about the test question, test item you're taking at that time, which in a speeded exam slows you down and stops you from performing as well as you do. When you get into medical school, you probably have not had a lot of contact with people of a different race. One of the things I asked when I was chair of the admissions committee at Pritzker was, have you ever had a conversation with an adult African American? Which was an important question to ask a white student who is now going to be working in a hospital that was predominantly African American with respect to its catchment area. But the idea on the reverse side is that African Americans typically don't have the opportunity to engage with whites in the same sort of way to disrupt those internalized racist stereotypes that they bring about their own intellectual capabilities. So you get stereotype disruption when you're a minority teacher teaching a non-minority residents, and it humanizes you to those residents as well. It demystifies white intellectual superiority because you realize that you're just as good as they are in terms of your intellectual capabilities, which mitigates stereotype threat and allows you to perform in ways without having to deal with the rumination during these tests. And this is what happens during residency, which is why I refer to residency as the great equalizer in terms of helping people to advance through stereotype threat and become more successful. Residency also helps you to disrupt the imposter syndrome when you work with people who are of a different race, shoulder to shoulder. You see that they don't know the same things that you do, that they have the same questions that you have, and that maybe you knew some things that they didn't know when they were asked. So it reinforces confidence, which I think is the number one problem we have with underrepresented minority residents in GME. It's undermining confidence that really it reinforces the imposter syndrome, the idea that you don't belong there because you don't see any evidence suggesting that you should be there because no one else is there. So Soman Saha actually saw another benefit. He asked medical students at the end of graduation on the medical school questionnaire whether they felt prepared to care for people of a different race and a different background based on their experiences in medical school. And what he found, to no surprise, is that the more diverse your medical school class was, the more likely you were to report that you felt more comfortable taking care of a diverse population of patients when you graduate. That there's something learned. You're humanized by seeing people who are different than you because you now understand them. So what's the tendency to go back and practice in these underserved areas at disproportion and to take on the roles that people do in academic medicine that cause them to study problems that don't get funded? Well, the idea is the Harvard group here is saying that there's race-conscious professionalism, and describes the process by which Black professionals and Latinx professionals confront when they attempt to navigate the compelling demands of professionalism, racial obligations, and personal integrity. And they found that Black and Hispanic physicians tend to leave minority communities once they settle in such areas, but when they move, they tend to resettle in areas that are very similar to what they've actually seen. So the role and recognition of professional responsibility in race is well documented, and we see it borne out by the numbers and disproportion by which Black physicians see Black patients and Latinx physicians see Latinx patients. But what's happened in graduate medical education over the last several years, from 2004, 2005, this is AC-GME data, up to 2018-19, is that we've gone from 4.9% of the residents who are in GME as being Black, all the way to 4.9% of the residents in GME being Black. And in Latinx circles, we have seen very little change. Now, there's more change in this last year than's taken place in the previous 13 years, and so I'll show you those numbers in just a second. But does this mean that the only solution to eliminate racial and ethnic health disparities is to increase diversity in the workforce? And the answer is no. The problem is it's a both and. You have to train everybody to think about how to eliminate health disparities, how to think about improving an inclusive work environment, and really thinking about cultural elements that will improve healthcare for their patients. But if you don't co-locate where the people are who are having the health disparities, then all that training will be for naught, because you will not see those individuals. So there's a both and quality to what we have to do. And I think the AC-GME work on looking at teaching everybody about disparities and also focusing on increasing the workforce that is of diverse backgrounds is the way to approach it. And this is a paper that's now 20 years old that asks the question, can cultural competency reduce racial and health disparities? You teach everybody about interpreter services. If you coordinate with health, teach them about coordinating with traditional health workers and traditional healers. If you build cultural humility and cultural experiences Will that improve healthcare alone? And their answer even 20 years ago was no, that's insufficient because you have to have that co-location as well. So let's look at our common program requirement changes that in greater depth and what we're expecting as the ACGME. So program requirement 1C asks the program in partnership with the sponsoring institution. We say that you must engage in practices that focus on a mission-driven, ongoing, systematic recruitment and retention of a diverse workforce of residents, fellows if present, faculty members, senior administrative staff in GME, and other relevant members of the academic community. So who's the target of diversity? Well, diversity can be seen across a broad variety of axes. It can include gender, orientation, race, age, ability, national origin, religion. All these sorts of things can be thought about it. But let's go back to the mission of the ACGME, which is to improve healthcare and population health. And if you want to do that, if your mission to drive workforce is consistent with driving the mission to improve health and population health, what you will focus on is the elimination of disparities. So if you find a disparity in your environment that you would like to eliminate, let's create a workforce that's consistent with trying to eliminate that disparity. So let's take away the identity aspect of who is diverse and focus more on the mission of what you'd like to accomplish. And that's how we're considering diversity in this whole prospect. Now, so we're open to the AMC's definition of this. Back in 2003, the AMC described something called URM, underrepresented minority, which were Blacks, Mexican Americans, Native Americans, and mainland Puerto Ricans. Vanessa Northington Gamble, who was then vice president for minority programs at AMC, went around the country and did a listening tour. And what she found out is that not every medical school was in an environment where there were these diverse populations. And that by using a national sort of perspective of looking at who's underrepresented minority, you were missing some important populations that were being underserved in the catchment areas of hospitals right there. So the sub-Asian population, for instance, if you broke that down into subgroups, you'd find that, say, Hmong people in San Francisco aren't really being treated the same in terms of their health demographics. So what you might want to focus on in that area, if you're an institution, is looking at subcategories of Asian populations that are more likely to serve that population that's underserved. So that's the idea. Wherever you are, from a local or regional perspective on underrepresentation, let's look at underrepresented in medicine individuals in that community that's going to solve that problem in health disparity. And you can take it away from the emphasis of those four groups, although we always want you to focus on those four groups because they remain perennially underserved, but you can expand your concept of diversity to include a broader range of racial and ethnic health self-descriptions. My colleague, Cato Lorenzen, an orthopedic surgeon and former dean at UConn, really went before the Institute of Medicine as well as the National Academy of Science and really pushed the idea that African-American men should always be part of the conversation when we're talking about expanding diversity within whatever discipline in science and medicine we're talking about. If you look at the ratio of African-American men in the gray and to women in red, what you'll find it's almost a 2-to-1 relationship. And that about 6 years ago, there were only 556 African-American men in the entire country who were admitted to medical school first-year classes. This remains a problem. If we look at the number of trainees actively enrolled in graduate medical education that the ACGME data shows us, we see that they're about 5.2%. We're up from that 4.9% now. In Latinx individuals, they're up to 6.2%. That's only about 6,000 people or so for African-American, about 7,300 for Latinx individuals. It's still very small compared to the 117,000 total people that we have in core programs training today. But the interesting thing is, if you look at this work from Sarah Brotherton and Sylvia Itzel, just published about a couple of weeks ago in the Med Education issue of JAMA, that in allopathic medical schools, African Americans represent only about 6% of medical school graduates in GME today. And that if you look at osteopathic schools, where the number of individual graduates is increasing, it only represents about 2.4% of the osteopathic community. So we really have work to do in the osteopathic community to really enhance diversity with respect to African Americans. But then you look at something that's very startling, which is that number, 28.5% of all Blacks who are in graduate medical education are not from the United States, are not from schools in the United States, which means that the international component of those individuals represents a huge fraction of the Black people who are in residency programs today. So it's something that we have to be very cognizant of as we're working to try to increase the number of people into the pathway of medicine, which is really the emphasis of what ACGME is trying to promote. So if you look by specialty, at overrepresentation with respect to specialty in individuals, you can see that 42.7% of the individuals, and I haven't done this for every year, I've taken selected years, and 2016-17 is the year that I looked at to try to do this analysis, that anesthesia is slightly overrepresented among whites compared to other disciplines. If you look at Asian physicians, that anesthesia is slightly overrepresented with Asians as well, 16.6% of the general population, 17.3% of anesthesiologists. If you look at Latinx physicians, you can see that they're well underrepresented in 2016-17 with respect to anesthesiology. So, but they represent about, I guess, the number 7 specialty in total numbers of people who are Latinx. For African Americans, anesthesiology is basically on par with the total number of anesthesia, with the total number of specialties, percentage of specialties for African Americans. It's also about number 6 or 7 in terms of the number of trainees back in 2016-17. Native American, slightly overrepresented, but there are only 17 Native Americans who are trained as anesthesiologists in the entire country right now. We hope that the new school down in Oklahoma State has an impact on those numbers of individuals very quickly. If you look at anesthesia, it's overrepresented in 2016-17 with males, with males representing 52.9% of all trainees, but 64% of anesthesiologists. And for women, it's underrepresented, with 44% of people who are in graduate medical education being women, with only 34% being anesthesiologists. But if you look at the real numbers, this is from Sylvia Itzel and Sarah Brotherton's work that was just published. The thing that really jumps out at me is the low number of individuals who are in specialty care. So there are only 9 critical care fellows in anesthesia in the entire country at this moment, according to their data. There are only 12 pediatric anesthesia fellows in the entire country who are African American. And so to me, 4 adult cardiothoracic anesthesia fellows in the country tells me that we have an opportunity as program directors, as fellowship directors in particular, to make a gigantic impact on the number and the diversity of individuals within our own specialty of anesthesiology and advanced specialties in anesthesiology if we pay a little more attention to trying to increase diversity through whatever mechanism that you can. And so what are we asking programs to do? Well, the emphasis will be initially on a process measure to show that you're trying to increase the diversity within medicine as a whole. And so we're not looking at you to look at your numbers of residents to see whether you've increased your numbers of residents in the short term, because there's a finite group of people and we don't want you to compete against one another to bring in more diverse residents. There are resources that you'd be spending to do that you could be using to help to try to advance people into careers in medicine, which we hope is what you'll take from this. We've included some new questions some new relevant questions on the resident and faculty survey to assess your efforts in this and to assess your efforts in trying to build a more inclusive requirement. But this is what we're going to use to base the idea that you're actually moving forward. And so substantial compliance with Common Program Requirement 1C means increase diversity and provide an inclusive environment. And how can you do it? Well, increase the number of diverse learners in pre-residency programs. We call them pathway programs now instead of pipeline programs, in deference to Native Americans who have issues with pipeline. We also ask you to try to increase your current numbers if you can, but don't spend a lot of resources and efforts against one another. And if you show that you're active work in trying to increase the pathway of individuals into medicine, eventually showing tracking and numbers of people who you've impacted, then your program will be in substantial compliance, even if you don't increase the number of residents in your current cohort of residents. So the idea is that we're not training enough underrepresented in medicine individuals that come to GME. GME's believed itself to be more of the recipient of the product as opposed to driver, the fountainhead in the old pipeline analogy. I'm going to stop using pipeline after this. But the idea is, can we turn the flow of individuals onto that pathway, reduce their deviation, and increase the number that make it to the end of the pathway? And that's really the goal of what we have in 1C. So here's the opportunity for you to work with STEM programs, STEM and STEM-M programs, where a community program can focus on working with local hospitals and local GME programs to try to increase their involvement. Academic medical centers have resources that can provide mentors and opportunities. They have also constructed barriers, such as one of the ones I encountered at the University of Chicago, where the lawyers didn't want people who were under 18 coming into adult hospital floors. Well, you can teach a 14-year-old about HIPAA. And when you put a white coat on a 14-year-old, they sit up a little bit straighter. And they actually behave more responsibly, I find, sometimes than the medical students do. So I think you can do this. And I think that you can overcome those barriers and remove those barriers to bring more individuals into your environment. So ongoing effort is, let's not just do a one and done. Let's have an ongoing relationship with the people we drive through. Let's figure out a way that we can track people over successive years to ensure that the work we're doing actually makes a difference. Multiple levels means that let's do it at the early undergraduate level, pre-undergraduate level. Let's do it at the college level. Let's do it at the medical school level, even at the post-baccalaureate level. Multiple levels in which we can try to address this. We also have an emphasis on trying to increase faculty. So let's look at our residents as our replacements one day and try to direct more diverse individuals into our programs. But we need to have better transparency around those people who separate from training, because we recognize that fit is sometimes a problem that's brought into question about underrepresented minorities who are in training environments. And one of the things about fit is that fewer than half of the people, we show here 48%, are dismissed from residency because of academic performance reasons. That means the majority of people who are dismissed from residencies are dismissed because of these fit issues. And so we really have to be careful about who we bring into our environments and how we treat them once they get there. Because what happens when you bring diversity into an environment that's unaccustomed to it? Well, you're going to have disastrous results if you don't prepare the ground, and which means you have to mitigate cultural underexposure and indifference. You have to try to see stereotypical projection. You have to try to reduce environmental triggers that feed this imposter syndrome I spoke about. And then you have to effectively address uncivil behavior. And so how do you do this? Through diversity education, implicit bias training, mandatory demonstration of competence. But in doing so, you often engender resentment and resistance from people in the workforce. And why is that? It's because sometimes the training isn't effective for that particular group. And people ask, why am I being subjected to this? So we have to figure out ways of making that training more direct, more effective for the roles that people are going to play. Are you going to be on a selection committee? Are you going to be on a CCC? Are you going to be in an environment in which I'm evaluating residents? I got to take off my structural racism hat and then evaluate people fairly in plain view. How do I do this? How do I mitigate bias? Where do you do it? Why you're doing the training, I think, is really important in making it more effective. And then you have to look at the persistence of the training. How often do you need to repeat it in order to be effective in terms of producing good work? So developing an inclusive learning environment is important. I'm going to show you some of the reasons why. This is a group out of Yale, Dow and Boat Rights Group, and they looked at underrepresented minority medical students on the annual graduation questionnaire in 2016-17. And what they found is that underrepresented minority and multiracial students found that the mistreatment rate was much higher than that for white students. That was 38% of all graduating medical students said that they were the victims of mistreatment during medical school. 32% or 33% nearly of multiracial students claimed the same. And that they found that discrimination on the basis of race and ethnicity was highest in those underrepresented minority groups, almost absent in the white group. And they found that underrepresented minority females with the intersectionality of both gender and racial discrimination bore the greatest burden of discrimination during the course of medical school. And so Carl Villamorio's group that actually did the first trial where they looked at duty hours attached also questions on that same survey about discrimination, abuse, harassment, and burnout in surgical residents. And they were able to work with the American College of Surgeons, American Board of Surgery, and the ACGME to attach their survey to the ABSITE exam, the in-training exam for surgeons. They got a 99.3% response rate, which means they captured almost every surgery trainee in the country with their study. And what they found that 32% of surgery residents reported discrimination based on gender, 17% reported discrimination based on race, 30% reported verbal and physical abuse or both, and 10% reported sexual harassment. 65% of women reported gender discrimination in surgery, 20% reported sexual harassment, and it came at the hands of residents, colleagues, patients, and attending surgeons, administrators, and nurses, all of it across the board. They dug down deeper on racial and ethnic discrimination in a second publication that came out earlier this year. And they found that 70% of Black residents reported they were victims of discrimination with respect to race. And for Blacks, what they said, that 40% of their Black residents say that there are different standards of evaluation for Blacks relative to whites, that they commit the same transgression and their punishment was greater. 17% felt they were denied opportunities on the basis of race. 25% were victims of slurs or hurtful comments. 62% were mistaken as non-physicians even as they were in physician roles in the hospital. 56% were mistaken by somebody on their own team as somebody else. This is what's referred to as a microaggression. And having repeated microaggressions is part of what the resident experiences for many minority residents. This is data from Dow and Boatwright's group at Yale, once again, showing that minority residents were victims of these barrages of microaggression and bias, that minority residents felt themselves tasked as race and ethnicity ambassadors, that they felt challenges negotiating professional and personal identity while being seen as the other. There are so many slights, so many things that happen to them in those environments. Some people would say that microaggressions are really not microaggressions at all, but they actually do have a bearing on your experience as a resident. This is Lottie Derby out of Mayo. And Lottie Derby wrote this paper in 2019 to follow up from an earlier study where she looked at medical students, and she found that when medical students are assessed with the Maslach inventory scale on burnout and well-being, burnout and depression rather, that the well-being scores of minority residents are actually better than majority residents, except if they've been the victims of discrimination, in which case they were far worse than the majority student scores. And she said the students from the racial and ethnic minorities experienced microaggressions that they attribute to their race more frequently than any other group, as Dow and Boatwright's group confirmed. And she felt that studies suggested the higher prevalence of depression syndromes among that subgroup of students was driven by factors within the learning environment rather than individual traits. And she compelled medical students to do more to improve the learning environment for non-white students. And this is extraordinarily important in what we do, because her other work in 2010 showed that burnout impairs your job performance, that your ability to focus wanes, your engagement with work suffers, you have feelings of hopelessness and apathy, there's increased irritability and emotional exhaustion, there's lack of productivity and poor performance. So what are you going to do if you evaluate a resident who demonstrates all of these things, the lack of ability to engage? Well, you're going to encourage them to withdraw from residency. And that's what we see. This is the AC-GME data looking from 2004, 2005 to 2018-19. And what we see is that the number or percentage of residents who withdrew from residency who are African-American is in disproportion to their numbers with respect to trainees and residencies, as we showed before. There were 4.9% of residents in 2015-16. We see that there are over 8% of residents who withdraw from residency. Further, we look at the people who are dismissed as a function of race and ethnicity. And what we see in the 2015-16 year is just absolutely startling, that 21% of everybody who was dismissed from a residency program, the 234 individuals who dismissed, were African-American. And that to me is unacceptable with respect to what we're doing with our learning environments in African-American candidates. If you look at individual specialties, our specialty in anesthesia, we see about 24% of individuals who were dismissed from residency were African-American in the green. That 5.9% were Hispanics. That's about on par where Hispanics are, but it shows that African-Americans are greatly overrepresented. And in internal medicine, 27% of all people dismissed are African-American. In OBGYN, 40% of everybody who's dismissed is either African-American or Latinx. In orthopedic surgery, 43% of people who are dismissed are African-American. In surgery, 26% of people who are dismissed. If you look at the odds ratio, the relative risk of being dismissed as a function of race compared to white residents being dismissed, what you'll find is that in our discipline anesthesia in 2015-16, there was a 10-fold greater risk of being dismissed if you were white, if you were black, relative to if you were white. In medicine, we find it's 12.3%. In orthopedic surgery, it was 31%, and in surgery, it's 6.1%, in pediatrics, 6.7%. So those numbers are extraordinarily important in looking at the differential impact as a function of race within our own specialty. But again, as I said, there's intersectionality between race and gender. And some of the work that Carl Belmorio pointed out is that if you look at racial discrimination, 1,200 of the 7,400 residents in their study were victims of racial discrimination. So that's 17% we talked about. But if you looked at how frequently it happens, a few times a year, said by nearly 1,000, 859. A few times a month, said by 368. So the incredible part about this is that these things are not uncommon in our training program. And when you're victims of discrimination and burnout, what happens? 38% of surgery residents reported burnout symptoms, but 4.5%, 333 individuals in our surgery training program had suicidal ideation. And this is really unacceptable in our clinical learning environments. And so 6B6 said that programs in partnership with their sponsoring institutions must provide professional, equitable, respectful, and civil environments that are free from discrimination, sexual and other forms of harassment, mistreatment, abuse, and coercion of students, residents, faculty, and staff. You say that's a big thing to bite off. One of my colleagues who's a DIO asked me immediately, well, what does civility mean? So this is Christine Porbeth, who's at Change Med Ed conference back in October of 2019. She writes the book Mastering Civility, and she says on her Twitter feed that incivility impairs performance, creativity, and even thinking for witnesses. People miss information right in front of them, and those likely around incivility are more likely to have dysfunctional or aggressive thoughts, although they may be unaware of the connection. And what she asked of that audience is, if you work in a civil environment, raise your left hand. And then she showed a list of 10 words, some that are more aggressive, about 4, some that were less aggressive, the other 6. And she asked people to raise their right hand when they saw a word they identified with. Oddly enough, you saw a large number of people who already had their hand up raise their hand when they saw the uncivil word, because that's what they related to. It was not even in their mind this was happening. They were unaware of the connection, but there it was. She also says that the human and business costs of incivility are much greater than you think, and people experiencing incivility have more difficulty getting off the sidelines and back into the game, which is the huge problem that we have in underrepresentation. I cite this Forbes article, and Jasmine Marceline, who's a colleague at the University of Nebraska, says for the past few weeks, she's talking about this past summer after the George Floyd murder and dealing with COVID patients as they were in Nebraska, I've existed with a cloud of sadness over me. I've cried frequently and been irritable. I've neglected most of my non-patient care duties. I've withdrawn from social media and virtual socialization with my friends. I'm exhausted physically and mentally. It takes a tremendous amount of energy to walk this path and still put on a brave face, pretending like nothing is wrong and being present for the people who are around you. This is the experience of our underrepresented minority colleagues in medicine. So this Macy's study has just actually come out. A full monograph from the conference that took place in February, right before COVID, that discussed the harmful effects of bias and eliminating discrimination in health profession learning environments, I think has 4 recommendations which are quite solid. We as institutions have to build a culture of fairness, respect, and anti-racism by making diversity, equity, and inclusion top priorities. We have to develop, assess, and improve systems to mitigate harmful biases, and look for and eliminate racism and all forms of discrimination. We have to integrate equity into health professions curriculum, explicitly aiming to mitigate the harmful effects of bias, exclusion, discrimination, racism, and other forms of repression. And we have to increase the diversity in our trainees and those who've been marginalized. So how do you assess for compliance if you're ACGME for the Common Program Requirement 6B6? Well, we have an Office of Resident Services, which houses the Complaints and Concerns function. Heretofore, ACGME really hasn't thought of itself as an advocate per se for conflict with residents in their programs. We're still not going to perform that role, but what we want is to hear about the complaints that are happening in the clinical learning environment. And if you cannot address those issues that are in violation of 6B6 locally with your own chair, with your own program directors, within your own GMEC and with your DIO, then this represents another opportunity to voice those concerns when you see the things that trigger a non-compliance event with 6B6. So complaints at acgme.org is certainly a way in which we can kind of help to enumerate, quantitate, and assess how we can help you to improve your environments. And remember that there's section 2A4A10, which is a requirement for program directors that say that they must provide a learning and working environment which residents have the opportunity to raise concerns, provide feedback in as confidential manner as appropriate without fear of intimidation or retaliation. We're trying to get at the truth at ACGME. We hope that people will contribute by helping us to make learning environments better. The last thing I'm going to talk about is first-time board pass rate. Really, the idea was that there's been a great emphasis placed on USMLE Step 1 performance in the past. It actually has the unintended consequence of causing all medical schools to drive a national curriculum so that people can actually be able to be compared to one another. But it de-emphasizes the individual distinctive strengths that medical schools have while they're engaged in this national curriculum. So I don't think that was the intent. And then what does really your performance on these standardized exams have to do with your practice ultimately? So this is a 2009 paper in JAMA published by David Ash. And what he looked at was the performance of obstetrician gynecologists in practice with respect to complication rate. And so we looked at parameters, individual parameters, whether your MCAT score, your USMLE Step 1, your first-time board pass rate, corresponded with how you practiced once you became a practicing obstetrician gynecologist with respect to complication rate. And what did he find? There was no correlation at all. But what he did find is that it correlated directly with the quality of your program. If you trained in a program that had a high complication rate, then you practiced as an obstetrician for the next 17 years with a high complication rate relative to your peers. If you went to a residency program that had a low complication rate, that persisted for 17 years as well. So it really undermines standardized testing as a metric of who's best. And that's one of the things I think that we have to look at very carefully as a profession to say, are we putting too much weight on standardized exams? Well, certainly this group out of Northwestern said that we are. That does the U.S. medical licensing exam step 1 and 2, are they valid for postgraduate medical education and residency selections? They found that scores were not associated with measures of clinical skill acquisition among advanced students, residents, and fellows. What the makers of the USMLE step exam, this is Don Melnick when he was president of the national board, wrote is that he pled with program directors to stop using USMLE step 1 scores for residency selection. And what did we find happens this past February? We found, and what the paper articulated was the use of holistic practices in selecting residents. And what actually happened this past February was that the board actually agreed to stop reporting the 3-digit score for step 1. We think that that's an important step in the maturation of the idea that the step exams should not dictate what happens to a resident with respect to selection for residency programs. And we're at a stage right now, Eric Holmboe, my colleague who runs the Milestones program, is looking at data to feed back to medical schools to give them performance analysis of how their students are performing. He's now working with the American Board of Medical Specialties to link data there, and ultimately to try to link ACGME and Milestones performance with practice performance in the same sort of way that David Ash has done to see what really matters with respect to Milestones and whether there's better ways that we can measure competency during training. I offer this last slide on performance on standardized exams from Jordan Cohn's paper back in 2003, which showed that there was a direct link between performance on standardized exams and parental income, and that the impact was greater for underrepresented minorities as opposed to non-underrepresented minorities, and that the poorer your family was. And there's a huge wealth gap that exists in this country, almost a 10-to-1 wealth gap that exists between blacks and whites, that really has an adverse impact on scoring ability for people who are taking these tests. What happens when you take away the USMLE as a metric of quality? Well, this group out in Oakland did this as well. Highland Hospital looked at its emergency medicine program, and in the period between 1990 and 2009, shows you the blue bars. And when they took it away and used a threshold of USMLE score, put more emphasis on what they call the Gestalt score, which is based on a holistic admissions practice. They formed diversity committees to help with their recruitment. What they found is that from 2010 to 2021, they were able to double the number of African-American trainees, almost triple the number of Latinx individuals, and increase the number of Asians who are able to come into their emergency medicine residency program, making it a much more diverse area. So what the board requirement now is, what the ACGME requirement around board certification is that we want everybody to take it. We want everybody to be above the 95th percentile in terms of their graduates, averaged over a 3-year period. And we want to ensure that if you're all over the 80% pass rate, you will have met this requirement no matter what the percentile rank is for the program in that specialty. And then finally, we're saying that we want to start collecting data now on a 7-year rolling average of what your graduates do. And I think that's an important shift to look at ultimate pass rate as opposed to first-time pass rate, which will de-emphasize that correlation that many people make between MCAT performance, USMLE Step 1 performance, and first-time board pass rate performance. People have said the ACGME is really the culprit at the core of program directors' over-reliance on scores, and hopefully over time, we'll see that this data is an ultimate board pass rate is a really important thing. Because our goal is to create board-certified physicians who practice and care for individuals to improve health and population health, and that's one of our major goals. So this is my contact information and my team. Please send us any emails if you have questions, and I'll stop right there. Mark?